Hello my dear friends. This is a case which is shared by one of my friend, and the dentist currently has a problem in obturating this tooth, and I have seen many practitioners in their early days of learning do face this situation. The issue here is that the file looks like it is reaching the working length on radiographic apex, but the GP is not going. And the second thing is, when the GP is tried to push little bit more, the patient is getting pain. So now let me explain you a very important point here, is that there are two things to note here. One, whether the pain is because you have not given local anesthesia. Now why is that important? Let us assume patient has come today and you gave the LA to the patient and you have done BMP, okay, and you sent the patient home. The patient came after 2 days and now you have not anesthetized it, and now you put the GP. But when the GP is trying to reach the apical 1/3, the patient gets pain. So what happens here is that you have not given anesthesia during the second time, and the patient is getting pain. That is why you get scared to obturate it to a proper working length. Then many practitioners would do it under obturation, and then it depends on host response whether the case will succeed or whether it will not succeed. So the most important thing to remember here is that majority times, even during the second appointment, even though you have done a biomechanical preparation in the first time, patient can still experience pain because you may still have some pulp tissue. So the right thing would be that you have to give local anesthesia and then try to put the cone. And maybe you might have to do slightly biomechanical preparation again, and then do the master cone assessment and then obturate it. Second thing is, you have not given anesthesia and the patient is getting pain. On the X-ray you clearly see that the GP cone has not reached the apex, but when you are pushing the GP beyond, or when you are pushing the GP and trying to reach the working length, because the patient is getting pain and you have not given anesthesia, you think you might have done complication like perforation, and you will be scared to take the GP to the radiographic apex. Now the most easiest thing to do here is to inject again and take the working length again with an apex locator, and then if you know how to use the apex locator, and if you can if the file is reaching the radiographic apex and that is where the apex locator is giving a proper reading, then it means that there is some pulp tissue and that is causing the problem, and it is not the perforation. So you need to confirm the working length with apex locator under anesthesia to be very sure that you have reached the working length. So regardless the patient has pain or no pain, it doesn't matter. Pain can always be controlled with local anesthesia, but it is the apex locator which will tell you whether you are short, whether you have done a apical transportation or a perforation, and then you can confidently do a obturation. Always remember, maxillary lateral incisors have a disto-palatal curvature. So majority times what we learn in our schooling is that you have to enlarge 3 times higher the apex from the initial binding size, which may not be always true. You may, because of the extreme curvature, you may have to do a smaller enlargement in the apical 1/3 and maybe a bigger enlargement in the rest of the straight canal. So that is generally explained on a concept called as working width, which you can definitely learn by various sources. And I hope these two things help you to do endodontics better.